Welcome to On Becoming a Healer. Today we're going to be speaking about the death of Matthew Perry, a TV and movie star, one especially beloved for his role as Chandler Bing in the TV show Friends. He died in 2023. The death involved a drug, ketamine. We're going to focus on the doctors connected to his death. To be very clear here, one doctor has pled guilty to federal charges. The other is charged, but we don't know yet what the courts will determine. Hi, Saul.
Hi, Stefan.
So, Saul, we're talking about Matthew Perry's death, and what made you think this might be worth discussing?
So when I read about this death, which we kind of heard about in stages initially, we heard that he had died of a drug overdose, and then more information came out, and it kind of evolved over a period of months as there was an investigation. And then finally, there were these revelations that two American physicians who had gone to excellent medical school, one is an emergency medicine physician, the other in medicine and pediatrics, had been involved in his death, and that there were text messages that they were just trying to make a buck, and that there was a very amoral component to it. One kind of chilling text that has circulated around in the media is when Dr. Placencia, and again, I'm not sure I'm pronouncing his name correctly, but Dr. P, as he's often referred to, was texting Mark Chavez, who he had worked closely with and knew well, and said, quote, "I wonder how much this moron will pay. Let's find out."
Oh, my God.
And this was part of a process where they were getting lots and lots of ketamine to, in some cases directly to Mr. Perry, and in other cases to those who were close to him and could help administer it. Now, once I heard this story, I was never somebody who watched Friends, and so I ended up downloading his memoir called Friends, Lovers, and the Big Terrible Thing, which is very moving. It was published in 2022, so not that long before he died. And it's just a deep dive into the suffering that he experienced as he wrestled with addiction. It was really, really epic. And it certainly humanized him for me. But what I'm also hoping to do in today's conversation is to ask a more fundamental question, which is, are these doctors kind of outliers? Are they bad apples? Or are they actually two-bit players in a system that is deeply corrupt, and that we really need to turn the mirror on ourselves? And I've been thinking a lot about this because my initial instinct was, thank goodness there aren't too many doctors like this.
Yes.
This is awful.
Sure.
But I'm actually going to, I'll just tell you right up front, I'm going to actually be putting forth the opposite argument, which is that actually we need to look at ourselves in the mirror here. And so that's why I think this is actually a much larger conversation than a rogue doctors and what to do about them.
And to the extent that I can, I will attempt to challenge you on that. And in order to bring us into the story, I need to offer some background for our listeners. And these are things I also had to learn. I hadn't watched Friends. So let's start with Matthew Perry. He was born in Canada. He died in his 50s in 2023. He published an autobiography in 2022 called Friends, Lovers, and the Big Terrible Thing, as you mentioned. In it, Perry is shockingly honest, very funny, and very clear about the nature of his own suffering, including his addictions to alcohol and prescription opioids. He grew up as a kid who didn't feel right inside, he says, particularly after his parents divorced. But he was extremely good at getting his mother and others to laugh, even when, he says, he didn't feel right inside. In his teens, he moved to California and gradually sought work in Hollywood, and eventually got onto the TV show Friends that ran for 10 years and still is lauded today. But he also had a very public experience of addiction. And when he wrote his autobiography in 2022, he reported that he had spent roughly half his adult life in rehabs, spending close to $9 million on his own addiction treatment. He describes his path to addiction as beginning in his teen years with alcohol. And he often describes it as part of an exchange in which he sought fame and lost a lot of other things. Early on in his career, he describes a conversation with God in which he says to God, "If you make me famous, I will give you anything." And he later reflects on that exchange as one in which he ultimately gave up a great deal in exchange for getting that fame. Much of the book is an exposition about what Matthew Perry gave, and not that he blames God, he blames himself. He spent at least half of his adult life in rehab programs. In 2022, when his book came out, he reported having been sober for 18 months. And then on October 28th, 2023, he died in his hot tub, face down. The LA medical examiner ruled it was an accident related to the drug ketamine, which we're about to talk about, and I'll get to that. But Saul, before I go further on ketamine and how he died, I just want to ask if you have further observations on Matthew Perry himself.
No, I think that's a very nice overview, and it's important to appreciate that, he is one of hundreds or tens of thousands, just countless numbers of people who struggle with addiction and who are highly, highly vulnerable. And I think there's a tendency to be less sympathetic towards individuals who are super rich and famous and to say, oh, well, they had all the possible resources. I mean, just the fact that you could even spend $9 million on treatment is mind-boggling. And at the same time, as I kind of wrestled with that thought that maybe he is deserving of less sympathy because he was super rich, I came to appreciate, and this will become clear as the story evolved, that his wealth was in some sense irrelevant when it came to the interactions that occurred with the physicians we're going to talk about who may have contributed to his death. He was basically just a very vulnerable and needy person, as all people with addiction are, with a craving, who is desperate, and they were the ones with the power. And I think that's a fundamental truth about being a physician, that, and particularly when you're dealing with people who are highly vulnerable, that there is that incredible power that can be used or misused that you have, because not only that you have expert knowledge, but in this case, you have access to something the patient physically wants and desperately wants, and that they can't get all that without you. So I think that's an important point that I would make here, that while Perry in one respect is unique, he was a celebrity. He got this incredible investigation after his death, partly because of the intense interest in him. But in another sense, this is a universal story of addiction and suffering from addiction and vulnerability that we've seen across this country in very painful ways in the last decade or so.
And I really agree with that. The story of Perry's death involves ketamine, which was found at very high levels in him when he drowned in his own hot tub. Ketamine, for background, is an anesthetic drug. It's been used at times as a party drug. At lower doses, there is a version that's approved for the treatment of depression. But ketamine clinics in the United States offer it by injection, sometimes nasally, for depression, alcohol use disorder, anxiety, PTSD. There's some literature suggesting it may be helpful for these things, but as often happens in the United States, the market for it has really taken off. According to an industry report, the ketamine market in 2023 was worth $3.4 billion and growing. And in writing his book in 2022, Perry does describe his prior experience getting ketamine at a ketamine clinic, and his description helps you understand what it does. He wrote, "Ketamine felt like a giant exhale. They'd bring me into a room, sit me down, put headphones on me, so I'd listen to music, blindfold me, and put an IV in. As I lay there in the pitch dark, I would dissociate, see things. I'd been in therapy for so long that I wasn't even freaked out by this. Oh, there's a horse over there? Fine, might as well be. As the music played and Kay ran through me, it all became about ego and the death of ego." Now, that was before 2022, before his autobiography. But the story of Perry's death involves two doctors, and I need to introduce them to you. One of the doctors is Junior and actually sold ketamine to Perry and to his assistant, and one of the doctors served as the mentor. The junior physician was Dr. Salvador Plasencia. He graduated from a top-tier medical school in 2010. It appears he was licensed, but not board-certified. He worked in an urgent care clinic in Southern California. And here's an interesting thing. On Yelp, there are 38 five-star reviews, and as best we can tell, these are authentic reviews. One reviewer wrote something pretty typical for them. They really get to know their patients. You're not just a body on a conveyor belt like at other urgent cares where they rush you in and out. This is completely different. It's the best, excellent service with that small town feeling. They really care. They take their time and actually listen to you and do everything they can to make you feel better. They get to know their patients. Saul, you checked these. You thought these were authentic reviews, right?
Yeah, and by the way, they is just Dr. P and his front desk
assistant
person. Yeah, and in many of them, they actually just refer to him as Dr. P. So they're definitely talking about him. And, I logged into Yelp. These are from many different people who review lots and lots of things, including other doctors. And many of them don't give 5 stars that readily, and they gave him 5 stars consistently. So it's pretty clear, and it's over several years. So the point is that I was convinced that this guy, this physician, has just been doing a great job. And again, it's so interesting because you have to juxtapose that again, that this is the same doctor who texted another doctor, Dr. Chavez, about how much to charge Mr. Perry for ketamine, writing, "I wonder how much this moron will pay. Let's find out."
So about Dr. P, His mentor, who I'm about to introduce, wrote on his LinkedIn page, "I worked closely with Dr. Plasencia as a coach and a mentor over many years and saw incredible growth in his personal and business development throughout our work together. And Dr. P also seems to have attempted a side gig in 2020, a telemedicine company listed on his LinkedIn page as Telemed. Now, his mentor was Dr. Mark Chavez, who graduated in 2004 from the same prestigious medical school. Dr. Chavez was, based on the ABMS website, board certified in emergency medicine. He has a website, and on his LinkedIn, he lists himself as, quote, longevity coach, medical doctor, entrepreneur, fitness trailblazer, and creator of the longevity resistance exercise method, close quote. And on LinkedIn, his mentee, Dr. Plasencia, endorses him. Mark has been a mentor of mine for 15 years. I've witnessed his transformation from a resident physician to an emergency room attending, health innovator, public speaker, fitness equipment inventor, and so on. He has been extremely helpful to me as I navigated my own path as a medical entrepreneur."
Now, I will say that in contrast to Dr. P, who has these 5-star reviews, I don't know what kind of reviews Dr. Chavez would have gotten, but I don't think they're quite the same. And again, this is all surmise. There was actually a comment in the New York Times comment section when there was an article about him. And one former patient wrote, quote, "Imagine my shock today when I saw the name Dr. Mark Chavez, the same doctor I decided to stop using as my doctor 10 years ago. He said, I didn't care for his bedside manner and advice he gave as I felt it was unprofessional and hurtful. He tried to sell my husband on his side gig of exercise equipment." So the sense you get with Dr. Chavez is, and to some degree, it's almost like this was starting to rub off on his mentee, Dr. P, was that they kind of were into this side gig thing. Like they're always peddling something. Like practicing medicine was not enough. So imagine how annoying it is when you're trying to see your doctor and he's trying to get you to buy exercise equipment.
Yeah, and I'll note here, and we could talk about it later, but certainly my father's own doctor also kind of expanded his practice to become a wellness center.
Yep.
Where for a period, there were rather large signs on the walls of the clinic waiting room when you went in, mostly related to enhancing your sexual functioning, which was kind of odd, if you're just there for a primary care visit. But there was a whole range of services that have kind of been established under the auspices of a private medical practice. So major news sources do describe Dr. Chavez as working in a ketamine clinic in the way that I described before, giving it in the clinic until roughly the middle of the summer of 2023. Remember, this is about 4 months before Matthew Perry's death. In that summer, Dr. Chavez stopped working at the ketamine clinic. He took some of the ketamine that was at the clinic with him when he left. And some of this apparently got to Dr. Plasencia, who wound up selling it to Matthew Perry. According to the New York Times, and here I'm quoting, Dr. Mark Chavez, who admitted to selling ketamine to Dr. Plasencia, obtained ketamine by making false representations to a wholesale ketamine distributor and by submitting a fraudulent prescription in the name of a former patient, officials said. And this is in the plea agreement to which he pled guilty. That sounds like it's in addition to the ketamine that he brought from the former clinic with him when he left. We don't know why or how assistants to Matthew Perry started to seek ketamine on his behalf. But in the reporting in the Times, initially, Dr. Plasencia reported it was being sought for help with smoking cessation, which is certainly not an FDA-approved use of that medication. It was coming to Matthew Perry through Dr. Plasencia, who was getting it from Dr. Chavez. Plasencia and Chavez allegedly charged $2,000 for a vial of ketamine that would cost Chavez about $12 to procure. According to the U.S. attorney, as reported in CNN, Plasencia wrote that he wanted to be Perry's sole supplier. Over the next several weeks, he purchased ketamine from Chavez, sold it to Perry's assistant, taught the assistant how to administer the drugs at home. But Plasencia also went to Perry's house to drop off ketamine and even injected the drug for Perry in the back of a vehicle in a parking lot of an aquarium, according to prosecutors. So that's kind of outlandish.
Yeah, it's interesting. When I was sort of wondering, like, where'd they come up with this idea that we're going to charge $2,000 for a small vial of ketamine, which apparently is about $12 according to the New York Times. Again, in the comments section, I came across people who wrote that they actually paid about $3,000 to get ketamine at official clinics for off-label indication, such as management of PTSD or depression. So again, I just want to comment that Chavez may have gotten the idea that, hey, $2,000 isn't such a bad thing to ask for. If he was working in a ketamine clinic, who knows what the heck they were charging people in the so-called legitimate business of ketamine administration.
Yeah, I mean, it reminds me of a friend of mine describing his work at a major academic medical center where they said, our goal is to help patients get to destination care. And destination care referred to those services that were high remunerated, like certain kinds of surgery, chemotherapy, and things like that. So there was a markup interest even in the very legit businesses, I'm sure we're going to come back to. Now, there were very much indications of danger to Mr. Perry during this period of September and October, according to the Times. They say that court papers refer to several instances in which Matthew Perry experienced adverse effects from the drug, including once when his assistant found him unconscious. And there's this ongoing back and forth between the doctors and text messages. As reported in LA Mag, according to the plea agreement prepared for Chavez, days before Perry died, Dr. Plasencia sent a text message to his mentor that read, "Do you think I should stop the current arrangement I have with Perry?" And Chavez answered, "It depends on your tolerance for risk." Kind of a cold statement. And I want to stipulate for anyone who's followed the story that there is another supplier that we haven't yet mentioned. And it isn't crystal clear when they stepped in, but it was probably in October. Charges have been made not only against the doctors involved, but also to an illicit market source who is described in some of the papers from prosecutors as having produced or offered the actual ketamine that was used on the day of Matthew Perry's death, that is October 28th. And what happened on that day, it appears, is that Matthew Perry requested that his assistant inject him more than once, and one time asked for an injection just 40 minutes after the prior one. And the quote in the New York Times is, "Shoot me up with a big one." And Mr. Iwamasa, his assistant, did so, and then actually left the house to run some errands, according to court papers. And when he returned, he found Matthew Perry face down in the water dead. And the autopsy report is that this is a accidental death, and ketamine is considered the source, although I think what we infer here is that the ketamine was at very high levels. That's reported by the LA Medical Examiner, and caused Mr. Perry to lose awareness of his surroundings and to drown, which seems like is likely what happened.
I think that's an important point. I'm not an anesthesiologist, but my understanding is that that is probably what happened. In other words, ketamine is a dissociative agent as opposed to one that shuts off your respiration. And in that respect, in a weird way, it's considered pretty safe. It's used in battle settings because it doesn't generally suppress your respiration. What killed Perry was probably getting into that hot tub and then taking an agent that essentially made him unaware, and then he drowned. That seems to be the mechanism here, if I understand correctly. Is that your take on it as well?
That's also my take. And before we talk about the doctors, I just want to say personally, having listened to about half of Mr. Perry's autobiography and watching him on television, I do feel this is an extraordinary tragedy. The power of his personality is remarkable. The willingness to self-criticize and to do so in such a humorous way makes his autobiography absolutely spellbinding. And this is a terrible loss.
Yeah, and it's also what made it particularly tragic, and I did finish the book, is the growth that occurs over the course of the story of his life. And that at the time when he died, he had thought deeply about who he is and how he wanted to spend the rest of his life. This was a man who had very, very low self-esteem, who didn't feel like he could be loved unless he was funny. And this is how he describes himself. And that it had made it impossible for him to have healthy, intimate relationships that lasted. He never married, even though he was super coveted for his handsome looks and charm and so forth. And at the point where he was writing the autobiography, which is, again, shortly before he died, he had kind of found himself in a way. And by the way, he had testified before Congress on behalf of veterans with addiction. He had started becoming an advocate. He'd found that his real joy in life was advocating for others who had addiction. He was starting to realize that he was at peace with himself and that he could finally, hopefully, develop intimate relationships. And so there's something especially poignant and almost agonizing about seeing that life cut short.
Yeah, absolutely. And so, acknowledging that, we want to turn to the doctors who seem to have played a role in the months before his death. And I want to ask you, Saul, what do we call the behavior of the doctors? It's criminal from the standpoint of the prosecutors and one who has pled guilty. Is it also non-professional? What do we call it?
It's absolutely all of those things. And if I had to come up with one word, I would say atrocious. But, and here's where I'm going to make a leap. I think that it's easy for us to marginalize this type of behavior and say this is beyond the pale of what we do in healthcare. And that intuitively makes sense. And certainly from a legal perspective, it probably is. Although I'm not an attorney, and the lawyers and the judges and the jury, if there is one, will decide on the legal outcome here. And by the way, I don't think it's necessarily that clear-cut when you dig deep into it. From what I understand, the ketamine that he got during the last few weeks of his life actually didn't come from these two physicians. They were probably breaking the law in a number of ways in terms of
the Controlled Substances Act.
Controlled substances, that they were misappropriating. Apparently, Chavez had written a prescription saying it was for somebody else so that he could divert it. Dr. P was clearly not giving the dose that you would give in the therapeutic range. And then finally, he actually apparently lied. He created false reports implying that this was a medical relationship and that he had dosed it appropriately. That is in and of itself a serious felony with long-term prison implications. So all of that is playing out in court. But I want to turn now to some of the other things that are happening in healthcare. And there's one example that came to mind as I was sort of reflecting on it. I recently was reading a paper, and actually it was one of several, by surgeons interested in the whole issue of patient safety in surgery. And one particular paper talks about the number of surgeries, in this case in orthopedics, that are done on a massive scale around the country, not only for which there is an absence of evidence, but for which there is an evidence of absence of benefit, and where there have actually been sham surgeries, rigorous randomized controlled trials showing that the surgery is not effective compared to placebo, and yet where these surgeries continue to be done on a massive scale across the country. Obviously, having your back cut open is never benign, and in many cases there are severely deleterious outcomes. And the question, of course, is what are the ethics of doing something like that to people, to thousands of people, to tens of thousands of people, and in some cases to hundreds of thousands of people. I'll get to that in a minute. When it's not just that there's an absence of evidence, but there is very strong evidence, RCT evidence, that what you are doing is of no benefit clinically. And well, by the way, what I'm reading to you is coming from surgery journals written by surgeons who are concerned about this. And so...
Yeah, please share. I want to hear this.
Yeah, so a couple of things. So first of all, there was a paper that came out in the journal Patient Safety in Surgery, and this is actually from 2017. And it's called Why Do Surgeons Continue to Perform Unnecessary Surgery? And the author writes, in 2016, the existence of unnecessary surgery remains a daunting reality that continues to expose our patients to an unjustified surgical risk. For example, multiple clinical trials have shown that spinal fusions for back pain do not lead to improved long-term patient outcomes when compared to non-operative treatment modalities, including physical therapy and core strengthening exercises. In spite of these insights from high-quality trials, spinal fusion rates continue to dramatically increase in the United States. Another relevant example is arthroscopic partial meniscectomy, one of the most commonly performed surgical procedures in the world. This minimally invasive surgery allows treating internal knee damage through small percutaneous skin lesions with a fast-track post-operative recovery period. In the United States alone, surgeons perform approximately 700,000 arthroscopic partial meniscectomies every year. Strikingly, a recently published prospective randomized controlled trial called the Fidelity Trial assessed patient outcomes after arthroscopic meniscectomy trimming compared to sham surgery, and it revealed no benefit for patients from the routine surgical procedure at 12 months follow-up. Actually, considering the risk for patients sustaining a severe intra- or post-operative complication, no surgical procedure should be considered routine from the patient's perspective. Yet, until present, a change in practice has not occurred, and arthroscopic meniscectomies continue to be performed on hundreds of thousands of patients in the United States every year. So the other example I want to give is from a 2024 paper called Unnecessary Care in Orthopedic Surgery. Again, written by surgeons, they say that there is a near linear relationship that exists between the number of spine surgeons per capita and the number of spine surgery procedures performed. And then they go through some of the data in support of these various procedures. And they write that concerningly, 16% of procedures that were done had RCT evidence comparing operative and non-operative management which did not support the procedure over non-operative alternatives. There had been randomized controlled trials showing that these procedures are not effective. And again, I want to distinguish that from uncertainty situations. They said in 37% of these surgeries, there's just a lack of evidence. But in 16%, there is the best quality evidence that they are not effective. it then goes on to say a 2021 study by Blum and others studied the evidence-based underlying 10 of the most common elective orthopedic surgeries by reviewing meta-analyses of RCTs. Okay, now the key points from this paper, they found RCT evidence supporting the superiority of just 2 of the 10 procedures over non-operative management, and that 2 other of the 10 procedures had no RCTs specifically comparing them with non-operative management. But most importantly, 6 of the 10 most commonly done procedures showed no benefit of surgery compared to non-operative management in rigorous randomized controlled trials. I could go on, but the point is that there are, on a huge scale, surgical procedures that are done for which there is strong evidence that they are not effective. Now, I'm not picking on orthopedic surgery. In fact, when I started Googling greed in healthcare, one of the first articles that came up was a piece in Kevin MD that was written by an internist who cares for patients with vascular disease.
Yes.
And he talked about how frustrated he was at the number of vascular surgeons who were talking patients into surgeries on their legs that he said there was no evidence they would benefit from, and in fact would harvest veins that they might need later if they ever needed coronary artery bypass grafting. Now, I don't start with that because this is just a guy, an internist writing in Kevin MD about his perception. But I think the point is that on a huge scale in this country, we are doing things that we profit from that are proven to be ineffective. At least we have the strongest possible evidence that they're ineffective, and that are highly invasive and harmful by the nature of their being invasive, where there is no evidence of where there is evidence of no benefit. And so I think I want to pause for a moment because none of this is illegal. These people are not going to go to court for this. But we have to ask ourselves, is it any different? Is it really any different? Because if you're a patient, again, we're talking about if you're a patient, is there really a difference between being subjected to procedures that involve cutting you open and generating lots of profit for somebody for which there is evidence that you will not benefit, and being, say, a Matthew Perry and having a couple of 2-bit docs who don't know how to do surgery, that's not what they do, but who want a piece of the action and give you medications at a dose for which there is evidence that it will harm you and that it will not benefit you to make a buck. And I think that's the issue that I'm wrestling with.
There is a difference, I would argue. And
a legal difference. There's definitely a legal difference.
No. So first of all, I think we could talk about a difference at the level of the types of evidence you've described, and also a difference at the level of the motivations of doctors, which we can't always know, to be completely honest. But first of all, I want to at least put a flag down that when we have a large randomized control trial that shows that a surgery is not superior to conservative management among those who consented to be randomized, or we find this also with opioids, long-term opioid therapies administered fairly aggressively were not superior to a relatively modest set of therapies offered to people who consented to be randomized with chronic knee and back pain. In all those instances, it's always still possible that in a good faith way, you try one treatment, and if your patient is no better, you often do try the next one. And the problem is that maybe on a randomized trial basis, it isn't superior, but it's the next thing for this patient, given that the last thing has failed. And offering that next thing, I fully grant that offering the next thing when it results in a whole bunch of money to you is a highly suspect action. But I do not want to assume that every time there's a randomized controlled trial showing no difference among people who consented to be randomized, that means that the more intensive thing has no value for a person when other things have failed. What do you say to that?
I don't buy it. I think that the term unnecessary surgery, which is used in this in these articles, is a bit of a euphemism. I think that what you're saying would make sense if it was happening on a small scale. So if on occasion a patient who had exhausted every possible intervention and their surgeon were, again, to say to them, look, I could operate on you. I just need to tell you that there have been high-quality studies involving sham surgery that show no benefit. This procedure, therefore, is not shown to be beneficial. This is a very unique situation. I don't do this very often, But maybe, if you really want to give it a shot, I think I can live with my conscience to do this if you fully understand that there could be serious consequences. And so forth. So with that type of preamble, I could see on rare occasion. But that's not what we're seeing here. What this guy is saying is that the use of these surgeries are exploding. He says in the face of data that says that they are ineffective, exploding on a massive scale. So that, I think, is where you have to say, is this really about physicians who are just on that rare occasion, willing to cross a line to help the occasional desperate patient? I don't think so.
That's fair. So now we need to go to the fact that we're talking about, in the case of the surgeons, but also in the case of internists who do interventions very often, but even in some of us who prescribe, there's a blossoming industry that involves making a whole bunch of money in what one of my colleagues' academic medical centers refer to as destination healthcare, where the highest profit margins are to be realized.
Yeah, and I want to go back to the word atrocious, because you asked me what I thought of the behavior. If I had to come up with a word to describe the behavior of Dr. Shav and Dr.
As
P,
alleged.
Dr. Chavez and Dr. P, as alleged, and I would say it's atrocious. But I also think that we need to call out what we're seeing on a much larger scale as atrocious rather than unnecessary. Now, I will agree that there is a middle ground. There are certainly procedures for which there is an absence of evidence, although what's interesting there is how little interest there is in attempting to see if there is evidence. In the same review that I was reading to you, the author writes, a review focusing on the evidence for surgery for chronic musculoskeletal pain found that less than 1% of published RCTs on the most common surgical procedures for musculoskeletal pain compared surgery to not performing the procedure, and that most of those studies demonstrated no benefit of the procedure when compared to non-operative treatment. So there seems to be a shockingly low level of interest in actually doing research to see if these surgeries are effective. And the very small number of rigorous studies that have been done have shown that most of those studies demonstrated they're not effective. And so I think we have to ask ourselves, why is there this incredible incuriosity about doing research on something that is so lucrative when the evidence suggests that you might not want to find out the answer to that question, particularly given that the small number of studies show a lack of efficacy. So I think we have to ask ourselves whether this is really being driven by integrity and an interest in the well-being of patients, or whether this is a much more shocking example of capitalism run amok with obvious harm to large numbers of patients.
So let's put a flag here that we are going to keep going at that. But I do think a fair number of listeners will probably say, look, the type of person who injects a drug to someone in the parking lot of an aquarium is somehow engaged in a very, very deviant, I don't know what the right word is, behavior. The type of doctor who keeps on doing knee surgery after knee surgery because Medicare will pay for it is doing a mainstream behavior. Aren't those just inherently vastly different?
Yeah, and I think the interesting thing is that if you're a patient, are they different, right? So certainly from the standpoint of the law and the regulatory and cultural environment of medicine, they look very, very different. But the question, of course, is that essentially that idea of kind of marginalizing certain types of deviance while mainstreaming other kinds of deviance, is that just a way of the latter, of mainstreaming? Because if you're a patient, is there really a difference? If your back or your neck or whatever is wrecked for decades because of something you agreed to that causes you untold suffering for which there was evidence of no benefit, is that really different than somebody shooting you up in a parking lot? It certainly looks different. But if you're the patient, is it really different? And by the way, I just want to make it clear, and in no way to minimize what Dr. Chavez and Dr. P allegedly did, but they did not give a drug that they thought was going to kill this man.
No.
What happened, unfortunately, is he climbed into a tub, and actually it appears that was a few weeks after they had last given him medication. Yes, and he actually died of ketamine that someone else had given him. But the point is, they were just trying to make a buck, and they made a buck, and they weren't trying to harm him, and they didn't think that what they were going to do was going to harm him. And in general, ketamine is pretty safe, is my understanding, even in these very high doses if you don't climb into a hot tub. And then finally, and again, don't get me wrong, what they did was atrocious, and and again, from a legal standpoint, it was very likely criminal. But I just want to step back and say, if you're a patient, these guys are two-bit players compared to what the industry itself is doing on a massive scale. In terms of the harm that it's inflicting on people.
I think I have to agree with you on that. And this brings us to the question of how we as physicians consider what motivates us in medicine. And in your book, On Becoming a Healer, which I really do encourage people to purchase, in your last chapter, there's something you call an organizing principle. That is something that guides us to be what we are. It guides our actions in terms of what we wish to pursue. And I'm wondering if we could find a passage from that book to explain what an organizing principle is, so we can talk about what is the organizing principle for these doctors and potentially for destination healthcare and large academic medical centers seeking to give as many surgeries as possible.
So at the time I wrote, organizing principles are reflected in our behavior. We perceive them as a drive to do certain things or simply as an unconscious response to particular situations. They show who we really are. This is in contrast to our espoused values or even our identities, which reflect what we believe about ourselves or would like others to believe about us. I also write that when different organizing principles coexist in a single person, they can either compete or conflict. So, organizing principles conflict when one directly undermines the other. It is not possible to be a healer who also swindles, bullies, or sexually harasses people. A healer is someone who respects boundaries consistently, not selectively. On the other hand, there is no reason a healer couldn't acquire wealth by building a successful business that employs people, has a respectful culture, and provides a needed service. So what I'm getting here is the idea that all of us are driven by a variety of motivations, which are the things that make us tick as opposed to the things we say make us tick. And so the reality is we often have somewhat competing organizing principles. On the one hand, we may genuinely want to help people. On the other hand, we may also genuinely want to make some money. Those two are not necessarily incompatible, but they certainly can be in tension with each other if one supersedes the other. Organizing principles can be both things that are generally associated as good things, like we want to make other people feel better. We want to have a meaningful difference in the lives of others. Matthew Perry talked about discovering that about himself, for instance, in the desire and the drive to help other people with addiction, and how that sustained him. In the same way, we might seek status, or maybe we want sex, or maybe we want to get super rich. And sometimes those organizing principles are simply incompatible with being a healer. So in the case of Dr. P, we see a doctor who, and again, you can never get into somebody's head, but you can look at what they do. And so organizing principles are often reflected in people's behaviors. Those horrible texts where he's talking about seeing how much money they can make and dehumanizing Matthew Perry appears to be driven by an organizing principle that involves seeking wealth. You also wonder about his relationship with Mark Chavez, who he admired, who is his mentor. Is he trying to impress him? There's also the 38 five-star reviews where he seems just consistently, genuinely committed to the well-being of his patients. Now, you could say he was just trying to make his practice successful. Who knows? But the point is, those comments, which are often quite extensive, suggest somebody who has a genuine caring quality to him as well. So I think one of the points of the chapter on organizing principles in On Becoming Healer, it's an opportunity for medical educators to have conversations with learners, with medical students and residents that go beyond the sort of narrow framework of teaching ethics, which is often, what is it? It's
medical ethics involves something like a respect for autonomy, beneficence, justice, and one other thing.
Non-malfeasance,
I think. That's it. Non-malfeasance.
Yeah. So I remember learning those four, and it all was kind of sort of like, okay, I need to remember this for a multiple choice test. Like this could be on the boards or whatever. And I think that what I certainly didn't get, any of our listeners are doing this, is a curriculum that looks in a much greater depth at why we go awry, why we go astray. And I think we need to look at, who are we? What are our organizing principles? And be very honest about it, okay? And that requires a fair amount of self-reflection and requires honesty. And it requires creating an environment where you can feel safe talking about your organizing principles without feeling like, and that it gets back to our episode last month on narrative medicine, where I said, if you don't have a safe environment where people feel like, they know they're not going to be graded, they can talk very honestly about who they are and the tensions they experience. Like, I wonder, could that make a difference? I don't know if Dr. P could have benefited from that, or maybe he would have done the same thing. I don't know. And then also maybe looking at case studies and asking questions about our profession and looking at what it means to do, for instance, procedures on patients when there is a strong evidence that they're not effective, and why we're doing that on such a large scale. So I do think that there is an opportunity within the way we train physicians to talk in much more honest terms about ourselves, the things that make us tick, and the way in which rampant capitalism, late stage, out of control capitalism has affected the way in which we behave in practice. And also this whole culture of, I need to have a side gig, which you see with Dr. Chavez. Everybody on their LinkedIn page has to have something else. It's not enough just to be a doctor taking good care of patients. You got to have a side gig. And I think that's another piece of this as well.
So first of all, capitalism made us do it. I mean, we're just going to put up a little red flag and say, On Becoming a Healer is about capitalism made us do the wrong thing?
Well, On Becoming a Healer is a book about a lot of things, about the journey to becoming a physician. And so it's not per se about capitalism.
Yes.
Oh, yeah, the podcast. Yeah. No, and our podcast is about many things too.
Yeah.
But I think that the role of capitalism, and we go back to the interview we did a few months ago with Martin Shapiro, who wrote a book about really the way in which capitalism has infected medicine to just an increasing and escalating degree. I mean, I have to mention that in yesterday's New York Times, there was, and I feel like I can't be shocked anymore, but there was an extraordinarily shocking expose about a for-profit psychiatric hospital chain that is huge now and is publicly traded, where they were kidnapping patients and not letting them out.
Oh my God.
Until they had maxed out their insurance.
Yes.
And they developed all of these tricks for keeping them for like another 4 days, for instance, until a judge could overrule and get these patients sprung, for whom there was really they didn't meet any threshold for being retained. Again, it's just wild to see that. But these stories just keep coming out. In that world, the Dr. P's and the Dr. Chavez's start to look like two-bit players. Atrocious two-bit players, don't get me wrong. But the much bigger story here is what the hell has happened. We always joke about the fact that you need to have a doctor in every house to protect, everybody from the healthcare system. In my family, where I'm the doctor, I would say my major role over the decades has been to prevent my family members and friends from having stuff done to them. And I'm thinking, for instance, way back years ago, I had a niece who's grown up now, but when she was just a young adolescent, she had chronic abdominal pain, and her family was going through enormous stress at the time. We know that young teenagers, particularly young girls, often have abdominal pain, particularly in stressful environments. And she ended up getting seen by a pediatric gastroenterologist, and then she ended up being seen by a pediatric surgeon, and he wanted to take out her gallbladder. And he said that he thought she had acalculous cholecystitis.
No stones, but inflammation.
Well, no stones. Yeah, exactly. And at the time, I was a little flabbergasted at the idea that you could have cholecystitis without the stones. But apparently you can. It's not typically in that particular setting, although it's not impossible. But long and short of it is, I just said, don't go there. Don't do it. And of course, she was fine. Patients rely on the sacred trust that they have to have with their doctor, that their doctor has their best interest, that their doctor is going to do what's best for them, that their doctor is somebody who they can trust. There's an incredible power imbalance because of expert knowledge. And also the person is suffering, the patient is suffering, they're so vulnerable and they want relief.
Yes.
And to have a profession where you can't count on that, where on a massive scale, things are being done to people, not in the absence of evidence, but when there is an evidence of absence of benefit with known harm. This is horrible. And I think that's, and in many ways, I was hoping that a little story like this, which is so tragic and shines a light on one life that was snuffed out in a way that was allegedly criminal, we need to turn that mirror around and look at ourselves and see how this fits into a much bigger picture.
So I know what one line of response to this would be. Capitalism done right wouldn't necessarily involve a rapacious relationship between healthcare providers and a federal payer in the insurance industry. Let's set that to the side for a moment. We can come back. But I think a lot of people are going to hear this and say, look, I go into medical school. I want to help heal people. I want to help people. Of course, I want to make enough money to live on. At some point, I'm working in a healthcare system where all the incentives go one way. And I feel bent by the system I am in. And this system is putting me in a position of moral injury and conflict. You're asking me to see 6 patients an hour. You're asking me to simultaneously document all of that. This is a system. I didn't choose it. And guess what? After doing that for 3 or 4 years, I wind up with a more cynical view about what I am doing. It's not my fault. It's the system I work in. And in that case, I'm not a criminal. My organizing principle is good at the start, but it got ruined by these guys over here who I work for.
So I guess my answer to that is regardless of where you are on the ideological spectrum, I ask you this question. Is it okay that on a massive scale, physicians are doing highly invasive things to people that involve cutting them open, things that they're undoubtedly not the usual activities of daily life, when there is evidence of no benefit.
That they don't help.
That they don't help. And then you yourself can decide why you think that's happening. I think it's pretty obvious why it's happening, because it's very profitable. Why else would it be happening? But, if you don't agree with that, if you think it's something else, the point is that it's horrible and it's wrong and it's hurting lots and lots of people. And it certainly is not consistent with do no harm, with the oath we take. And so the question we have to be asking ourselves as physicians is, why aren't we calling this atrocious? Why are we giving it labels like just overuse and unnecessary? It seems like it's sanitizing it. And we need to be having much more honest conversations. And how convenient is it that we can look at the sort of rogue doctors and say, well, they're the bad apples.
They're terrible.
They're the bad apples, right?
I'm not.
Exactly. And I think that I think is the work that we need to do.
Now it comes sort of who's we, right? So we are in a position where we might speak with medical educators, or we might even speak with institutions that present requirements for medical education. The AAMC issues statements about what should be pursued in medical education without necessarily declaring this specific curriculum. Is there a case to be made that these kinds of organizations should be reconsidering how they talk about unnecessary procedures, waste? If we have some influence, how are we supposed to use it? And I'm talking about people who have at least a way to get into a conversation with deans and such.
Yeah, I think that, for instance, again, I'm not picking on orthopedists because this was just an example, but I think, yeah, absolutely. It should go beyond the editorials written within surgery journals by concerned academic surgeons saying this is wrong, to being more public about it and to basically calling it out and saying we're going to sanction physicians who harm patients by doing procedures that have, unless they can, and again, you could always have a process where you could say, here's how you can request an exception. In this particular patient, for the following reasons, and would document that they have understood and consented to a procedure for which there is no evidence of benefit. And so you could make it much more of one of those things that, yes, you can appeal under humanitarian conditions for doing something like this, but that the general understanding is that it is negligent and wrong to do this stuff to patients, given the evidence. And and we are so far from that right now. In fact, we're going in the opposite direction. And as you can see from these concerned surgeons, they're saying, actually, these procedures are increasing. And so I think that that we need to call these things what they are. Is it going to happen? I don't think so. And why isn't it going to happen? It's because of the money, right? And so the question is physicians are not hard to corrupt. I remember years ago that all it took was some pizza to get us to show up with the drug reps would bring us a little bit of pizza and we'd show up and listen to them talk to us so that we could get a free lunch. So I don't think physicians are very hard to corrupt in general. So it's not, unfortunately, I'm not optimistic about it, but I do think that we need to try. And I think that, there are physicians who are deeply concerned. And so the question we have to ask ourselves is, in a system that's overwhelmingly driven by money and profit, is it possible for physicians to be ethical? And I would say the answer, certainly there are some physicians who are ethical, don't get me wrong.
Yes.
There are some physicians who are ethical, but I'm just talking about the profession writ large. And I think that is, I think that's a conversation that needs to be had in medical schools and in residencies, and needs to be talked about in the culture in which we practice.
One of the things that kind of stood out to me about the two doctors in the story with the death of Matthew Perry and who are somehow related to it are that one was an emergency room physician who was working in ketamine clinics, which suggests he was looking for an additional remunerative line of work. And the other was an urgent care doctor who probably wasn't making very much money compared to his peers. And so that sense of I should be doing better, I should be better rewarded financially might have been a factor. We don't know that for a fact, except that they certainly seem to seek money. But that sense of I should be making more than I am certainly is a personal motivation that probably affects a lot of people. And it doesn't seem to always be present at the time we enter medical school, but it's often present about 5 years after residency. And I wonder if we are not preparing people to face the feelings they're going to have about that.
I absolutely agree. I think that, physicians, even physicians who are, quote, at the bottom, who are poorly paid, are still in the top, say, 3% of U.S. income. And I'm not making that up. If you look at the numbers, and actually have a chapter on that even the lowest paid specialties are still at the very top of the income bracket for Americans. And so I think that, yes, but when you start to compare yourself, there's always this idea of it's kind of like you want to keep up with the Joneses.
Yeah.
Hey, I want a piece of this action. It's not enough just to have my practice and, maybe make a couple 100,000, 220, whatever. Look around me. Everybody else is making, 500, 600, 1 million, 1.2, whatever. I need a piece of that. And so I think that absolutely is something that needs to be talked about. And, again, it's pernicious.
The other thing that comes to mind for me is that, we've kind of issued a warning against, at one level, the way in which capitalism is played out in the U.S. healthcare market. We've also made a warning against how we, as physicians, think about money for ourselves. The flip side of that is how we think about the reward of healing relationships. And this gets back to your idea of organizing principles. That is, one of the things I've learned by working with you in this podcast and in reading your book and in just thinking about my own work is that it's incredibly rewarding when people make progress, even of a small nature, in their own lives toward their own health objectives, often achieving something that helps them and feels good to me. And I would love to see us help people in our own profession recognize that remains a high value, even 10 years out or 15 years out. And I don't think it can be done just through inspiring poems in Annals of Internal Medicine or New England Journal of Medicine about how great it is to be a healing presence. It's something more than that. And I have trouble laying my fingers on what it is.
I'm so glad you brought that up. I was in clinic recently. Actually, I was staffing acute care at the VA. I was on my own. I didn't have residents. And I was asked to go in and see a gentleman who was having shoulder pain. And one of the ED attendings said to me as I was heading in, "Oh, I just want you to know this guy's pretty difficult and he's not in a good mood." And I kind of smiled to myself because this is going to sound crazy, but I would kind of look forward to that. I feel like, okay, if there's strong emotion, this is going to be a meaningful interaction. And I went in there and I sat down with this guy. And I also have to say that, I don't know, maybe it's the nature of the life I've had over years as a physician, but I'm comfortable with being in that kind of water with another person. So I go in there and the patient was in a bad mood. And we spent about 20 minutes together. And during that time, I remember putting my hands on his shoulders, feeling the area of his shoulder where he was having pain, asking him to do active versus passive lifting for me, and just purposefully touching him gently. And I felt like the laying on of hands was going to be important here and just showing that I cared.
Yeah.
And he just, for lack of a better word, he just kind of melted. And it felt special at the end. It felt very special. I felt like I'd connected with this man. He had had a significant injury where he dislocated his shoulder when he was in the service, and it had been kind of a chronic issue. And, he was in pain. He was uncomfortable, but I think he felt cared for. And it was wonderful. And I feel like one of the pernicious effects of this sort of, and again, for me, I call it rampant capitalism, is it sucks all the joy out of medicine, that you become vulnerable to like, oh, well, I got to get a piece of the action. These other docs are making a buck. And that becomes almost like, you almost feel like, I'm a sucker if I'm earning less than the other guys. And that starts to eat away at you.
Yes.
And now that becomes the organizing principle that rises to the top. And it goes from just being a sort of normal human desire to, earn a decent living, to being a source of insecurity, that you're somehow missing out on the action, that other people are getting rich and you're not.
Yes.
And then all of a sudden, the pleasure and the joy of just being with another human being and helping them is lost. It's sucked away from you, and you don't have that anymore. And so I think that we have to recognize that it's a poison.
Yeah. So we've raised a warning flag. I think we're committed ourselves to nurturing a conversation which protects the specific idea of healing and to recognizing that the systems we work in are often oriented around other things than that. And I think what you're also acknowledging and what you're saying is that as we grow up, even at the tender age of one's mid-50s, like Matthew Perry was when he died, or like I am, we are not routinely always secure in who we are. We can be deviated by insecurities about what we've accomplished, about who's recognizing us, about what we're getting. And those pressures can be brought to a fierce point sometimes by our employers or by looking at how much money so-and-so is making. And we don't know for sure, but it sounds like maybe there is a version of that that played out in an atrocious and criminal sense, perhaps in the doctors who were involved in the ketamine distribution to Matthew Perry. There is a different but potentially highly related form of that that's playing out in our work and in our industry at this time. And I think we really need to be open and cautious and seeking to talk about it in medical education and in seeking to be more blunt about it when we write for the literature or when we speak to the leaders in the organizations where we work. That's kind of where I'm at as a result of this conversation. And I'm also very sad for the loss of Matthew Perry.
Yeah, and I guess I would close by going back to a question you asked earlier, which is, can physicians practice ethically and well in a system which, at least I regard, is overrun by a profit motive? And as I said, I'm sort of skeptical, but I do think that if it's possible, and it has to start with a full acknowledgement, a full facing of how it has affected us. And I saw the Matthew Perry example as interesting because it almost points us in the wrong direction. It almost gives us an opportunity to say, oh, those are bad apples, they're outliers.
Yes.
When in fact, I see it as an opportunity to have a conversation about, hey, wait a minute, what about the rest of us? Now, I will say I'm not a surgeon, I'm a generalist. And the thing about generalists is I'm not sure we're any more pure than the orthopedic surgeons.
We don't want to imply that.
We just don't have the skills to do all that profit seeking on that scale. It's not that we would be any more immune to it. And in fact, the tendency to kind of have a side gig, to do that little thing that can often lead you down the path that we see with these two guys who are not surgeons, is, I think, just an indication that the problem is that no specialty, no group of doctors are immune as a group to this type of corruption.
I agree. And Saul, as we close this, do you think we should let our listeners know where they could send a donation or join our Patreon for a mere $45 a month?
I think we should start a side gig, exactly, and folks can help us feel better about our non-surgical salaries.
Thank you so much, Saul, for this conversation.
Thanks, Stefan. We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.